Next, you had a 55-year-old woman who suffered a vertebral fracture. Her total hip T-score, so the T-score is when they do a DEXA scan, it comes up with a T-score. And the normal T-score is from negative, well, it's the normal T-score is fine, but if you get a score from -1 to -2.5, then they have osteopenia. It means that they don't have osteoporosis yet, but their bones are weak and prone to developing osteoporosis. If it's less than -2.5, then they have osteoporosis, and then anything else is normal. So above -1 is fine, but -1 to -2.5, that's osteopenia, and then less than -2.5, that's osteoporosis, and that's on the DEXA scan. So this 55-year-old woman suffered a vertebral fracture. So she had a DEXA scan. Her total hip T-score is -2.9, so she has osteoporosis in her hips, and in the lumbar spine, it's -3.5, so she had osteoporosis in her lumbar spine as well. She's intolerant of all bisphosphonates, even with weekly dosage. She experiences troublesome vasomotor symptoms, and there's a strong family history of breast cancer. What's the most appropriate treatment? So strontium is like calcium. It plays with the osteoclastic and osteoblastic activity of the bones and helps bones regenerate. So strontium would be the next best one. The other one would be raloxifene, because she has a strong family history of breast cancer. It will help with decreasing the chances of developing breast cancer. But the vasomotor symptoms would increase with the raloxifene, so that wouldn't be appropriate. So the best answer for her would be strontium. So yeah, so in this case, hormone replacement therapy is not possible because of the breast cancer risk, so that's ruled out hormone replacement therapy for her. Raloxifene might reduce her risk of further vertebral fractures, but non-vertebral fracture, it may also make her climacteric symptoms worse. So it just increases vasomotor symptoms, so it might make her vasomotor symptoms worse. And as she's intolerant of bisphosphonates, strontium would be the most appropriate next line. Okay. The next one, you have a 21-year-old woman who's evaluated for fever of 9 weeks duration. During this time, she's had daily temperatures of up to 40 degrees. She's had malaise and occasional aches in the hands and knees, and noted a transient pink rash on the abdomen. She's received a 1-week course of ampicillin provided by her GP with little effect. On examination, her temperature is 38.9, her pulse is 110, and she has a faint systolic ejection murmur. The spleen is palpable 3 centimeters below the left costal margin. ECG and chest radiograph are normal. Her investigations show hemoglobin is 115, white cell count is a little raised, ASO is 250, rheumatoid factor is negative, ANF is negative, and the blood cultures have been requested but are not as yet available. Which of the following is the most likely diagnosis? So 21-year-old, she's having daily fevers for the last 9 weeks, and it's up to 40 degrees Celsius. She's malaise, she has aches in her hands and her knees, and she had a transient pink rash as well. She had 1 week of ampicillin, but it didn't do anything. Her temperature, she's still febrile with a temperature of 38.9, and she has a faint systolic ejection murmur, but her pulse is 110, so it might just be because she's tachycardic. And the spleen is palpable 3 centimeters below the left costal margin. So from the things that we're seeing here, I've ruled out pretty much everything except adult onset Still's disease and bacterial endocarditis, but it doesn't really fit with bacterial endocarditis because it's been going on for 9 weeks. Also, the murmur, it would be pansystolic, not just systolic ejection murmur, ejection systolic. And also, they don't get a pink rash, so that would be more fitting with adults onset Still's disease. Also, the fact that she's having arthralgia, the weight aches in her hands and her feet, that makes more sense that it's something joint related. So adult onset Still's disease is a systemic inflammatory disorder, unknown etiology and pathogenesis. Typically, it affects young adults. Usually, they can have fevers that come every 4 days. They have a rash, they can get a pharyngitis, arthralgia, arthritis, hepatosplenomegaly. In this case, she had splenomegaly, and polyserositis, leukocytosis, and negative serological tests for ANA and rheumatoid factor, like in this case. And then you also have your criteria. You have your major criteria and your minor criteria for adult onset Still's disease. So you have major criteria: a high fever that lasts 1 week or longer, joint pain lasting 2 weeks or longer, a rash, and an abnormal white cell count. These are all major. And then for the minor, you have sore throat, swelling of the lymph nodes or the spleen, liver problems, and absence of rheumatoid arthritis. She checked pretty much a lot of them. So she had the high fever, the joint pain, the rash, the abnormal white cell count, all 4 major criteria. And in order to make a diagnosis, it would be 5, if a person has 5 or more, including 2 or more from the first major criteria. And so if she needs just 1 more, it would be the absence of rheumatoid arthritis because the rheumatoid factor was negative, or the swelling of the spleen because that was swollen as well. It's not uncommon to have a mildly raised ASO titer in inflammatory or infective conditions, and in active acute rheumatic fever, you'd expect an ASO titer of at least 500 to 1,000, so it doesn't really fit that this is rheumatic fever for her. And then the ejection systolic murmur is probably caused by the hyperdynamic circulation, and it would be unusual to get an ejection systolic murmur with rheumatic fever or bacterial endocarditis. Usually it's pansystolic with mitral regurg, or early diastolic if it's aortic regurgitation. And then also you don't have a pink rash with bacterial endocarditis. Okay. The next one, you have a 60-year-old waitress at the hospital canteen presents to the general medical clinic with a 2-month history of gritty sore eyes. She's developed tingling in her hands and feet in the previous 3 weeks. She also noticed that her mouth tends to be dry. She has, according to her husband, become a little confused in the last 2 months, sometimes forgetting where she is and how she got there. Her mood is worsened and she's prone to unprovoked emotional outbursts. Her past history is unremarkable, apart from treatment for Hashimoto's thyroiditis some years before. Her physical examination reveals increased tone throughout, with some distal sensory loss in all 4 limbs. Which diagnostic test is most likely to reveal the specific diagnosis? So, general medical 2-month history of gritty sore eyes, tingling in her hands and feet. Her mouth tends to be dry, and she's confused a little bit in the last 2 months, and her mood's worsened. She has emotional outbursts, and she had Hashimoto's thyroiditis. Okay, so and so it's either, for me, it would either be anti-Hu antibodies or anti-Ro antibodies. Ro is for the Sjogren's syndrome, and Hu would be for encephalitis. But the encephalitis just doesn't fit with the dry mouth. But Sjogren's, you can get, you get other symptoms other than dry hand or dry mouth. You get increased spasticity, which she's having because she has increased tone throughout, and some distal sensory loss as well. So that it's more fitting with Sjogren's syndrome than it is with encephalitis. Also, Sjogren's can come with Hashimoto's thyroiditis, so that makes Sjogren's more likely. Chest X-rays doesn't make sense. Nerve conduction status is inappropriate at this stage, and anti-nuclear antibodies doesn't make sense either. Oh, sorry. So anti-Ro would be the answer. So it appears that this patient has diffuse encephalitic process with episodes of confusion and emotional disturbance. There's also evidence of peripheral sensory neuropathy. The combination of CNS and peripheral nervous system involvement implies a multifocal process. So the differential would include vasculitic, hence the ANA, autoimmune, or paraneoplastic processes. The other clue is that she had dry eyes and a dry mouth. These all point towards Sjogren's syndrome, and Sjogren's syndrome include neuropathies, which can be sensory, motor, or mixed, and they can also get myopathy, as well as focal and non-focal involvement of the brain and spinal cord, resulting in a wide range of neurological symptoms, including deteriorating cognitive function, dementia, cerebellar syndrome, and transverse myelitis. Okay, with 29, you have a 25-year-old builder who presents with a 2-week history of deteriorating pain in both feet that feels as though he's walking on gravel, and a sore lower back. He returned from a holiday in Paris 2 months ago and has been aware of a transient urethral discharge for which he has received no treatment. What's the most likely diagnosis? So he's got transient urethral discharge. He has foot pain, deteriorating pain in both feet that feels as though he's walking gravel, and a sore lower back. So it sounds like, the triad, but he's missing the conjunctivitis. That's all he's missing for it to be reactive arthritis. But it's still more fitting than everything else. Drug-induced, it doesn't mention any history of drug. Gonococcal arthritis doesn't mention anything else, with the painful sores or the fact that he's been having unprotected sexual intercourse, anything of that sort. It doesn't mention any of that. Musculoskeletal pain is not enough. And Sjogren's syndrome doesn't make sense. It fits with reactive arthritis or Ritter syndrome. He's just missing the eye, the conjunctivitis. But Ritter syndrome, you get lower back pain as well as pain in your feet. So plantar fasciitis as well as sacroiliitis. You get urethritis, so pain. You can get urethral discharge as well as dysuria, and you get conjunctivitis. It's recognized to occur after GI infections with Shigella or Salmonella, and also tends to occur after non-specific urethritis. Gonococcal arthritis tends to occur in patients who are systemically unwell and have features of septic arthritis. So they'd be a lot more unwell if it was gonococcal, and it would be painful septic arthritis sort of joint picture. But in this case, it was just sore lower back, and both feet are painful. Okay. Next, you have a 71-year-old woman who requests a bone density scan as there's a maternal history of hip fracture. So she's fit and well herself, and there's no history of fracture. Her total hip T-score is -3.2, and T-score at the lumbar spine is -2.9. So she has osteoporosis. What's the most appropriate treatment in this case? So first line would be the alendronate, the bisphosphonate. So that would be the answer for her. She's not tried anything yet. So alendronate is appropriate for this woman. It will reduce the incidence of hip fractures and vertebral fractures. A well-documented side effect is that it can cause peptic ulcers. So that's something to keep in mind when you start this treatment. They have to be sitting up and drink lots of water whilst taking it.